Well, welcome. It's a privilege for me to be here, and I want to thank Rob Jackler and faculty for asking Dick and I to do this. I had a lot of fun preparing this talk. In fact, I had more fun preparing this talk than any talk in my career. And so there's not much data on the slides, but there's a lot of truth. So I just thought you might find this slide interesting. It's an old slide. It was one I made for a talk in 2001. And isn't it interesting that in 1900, JAMA said that we were going to have a cure for cancer, for all cancers, within 25 years. Isn't that interesting? And then during my residency and early onset here on faculty, it was immunotherapy that was going to be the great cure-all for head and neck cancer. It was the magic bullet, and it hasn't exactly panned out. And then in the 80s, we actually started the business with chemotherapy. It was interesting, Dr. Kalibas today in Tumor Board didn't know that the actual first group of patients treated with chemotherapy as a substitute for surgery were done right here in this hospital, and I presented that data at the combined meeting in Puerto Rico in 1983 or 84. And that protocol, I developed that protocol in my house watching a fire coming up through the valley, and Charlotte Jacobs and Don Goffinet and I were sitting there trying to dream up protocols for head and neck. And I said, why don't we do chemotherapy and see if we can get it as a substitute for surgery? Because we had had phenomenal success with cisplatin in the 70s. We used cisplatin before it was approved for head and neck. And so I was convinced that chemotherapy was going to be a substitute for surgery, and indeed it was. In the first series of patients, we had about 25% who were able to avoid either surgery on their primary or surgery on their neck as a result of chemotherapy. In the 90s, it was DNA unraveling. That hasn't exactly panned out. We've had some interesting developments, particularly, I think, someone asked me today, and I think biomarkers have particularly benefited from DNA unraveling. And suffice it to say, there is no magic bullet, and there probably isn't going to be a magic bullet, and that all we can expect to see is head and neck cancer improvement 5 to 10%. Well, that's significant, because when I started in 1970, when I started my residency, the cure rates were 55%. By the end of my residency and the start on the faculty here, the cure rates had increased to 65%. And now I think if anybody looked at this, probably the cure rates are probably in the neighborhood of 70 to 75%. So we have made progress over the last 40 years. And some of you don't know, but I've been here almost 40 years. I'm actually the young guy in the department because my compatriot's going to follow me. He's been here just a couple of years longer. Now, part of the fun and excitement in day-to-day medicine is knowing that you're going to learn new things. And we've all known that since we were medical students, right? They told us, when I was a medical student, they told us that the medical knowledge that we're going to have is good for 7 years. And now I think probably the medical knowledge that you have now is probably only good for 4 or maybe 5 years max. And that time interval is getting shorter and shorter. So you are, if you didn't know, you are entering a career of lifelong learning. And part of the fun, at least for me in medicine, was finding out the new things. And a lot of the new things I learned from my fellow faculty members, a lot I learned from residents, a lot I learned from nurses, a lot I learned from physicians' assistants, and a lot I've learned from patients. When I had a patient who walked into my clinic and said, I've got angiolymphatic malformation with eosinophilia, I didn't know what that was. I said, I'm sorry, I don't know what that is. He opened up his briefcase and handed me a series of papers on it. So, Chimera's disease is what it is, but I'd never heard of it before. So, So I'm glad I didn't know it all, but now that I do know it all, I have lots to tell. But mostly I want you to remember that Socrates said the only true wisdom is to know that you know nothing. And I can't emphasize that enough. Now, I wish I would have known that the new dean would give the department $10 million and be able to attract Rob Jackler. because I would have stepped down sooner and gone fishing earlier. You know, the growth and progress of this department over the last 8 years, 9 years, maybe 10 years, has been due to the dedicated efforts of Dr. Jackler and the rest of the faculty, but his leadership has put it all together. And only another chairman could really know just how much effort has been required to develop what he's developed. And among other things, and I would encourage you to follow his lead, is his leadership as a testimony of how valuable it is to have a positive relationship with the dean, which is something I never had. I hated the dean. I did not make it a secret that I didn't like the dean. Everybody in the Department of Surgery hated David Korn. He was the smartest, the hardest working, the brightest dean we've ever had since I've been here, and I've been through 8 deans now. But he was the meanest, low scumbag of the earth. And I didn't like it, and I didn't make any secret about it that I didn't like it. Okay, now to get more serious. I wish I had known that the presence of disease is not an indication for treatment. Most of you have heard me say this. Most of you know where I reference it. It came from a talk that I gave, a philosophical talk that I gave in 2001 in San Diego. And I think for a moment, if you think about the disease that your patient presents with, just ask yourself the question, do I really need to treat this disease? So here are some diseases that you don't need to treat. Papillary thyroid cancer, especially if it's less than 1 centimeter or if it's recurrent. We saw a patient in tumor board that would have required a laryngectomy, pharyngectomy, flap reconstruction, neck dissection, partial mandibulectomy, and we wouldn't have cured this guy. And he came and he asked me, I said, no, you don't need any surgery. You really want a surgery. He went to Harlan, asked Harlan for surgery. Harlan said, no, I don't do surgery, but no, I don't think you need treatment. And as far as I know, the guy's still alive, and that's been 4 or 5 years ago. Some patients don't need to be treated. Some patients with carotid body tumors don't need to be treated. Which ones do? Well, the 25% that grow. So my advice is if you have a person in their 60s who has a carotid body tumor, just bring them back in 6 months with another ultrasound. Get an ultrasound of their carotid body tumor, get another ultrasound. In most cases, you're going to find that ultrasound isn't going to change. And it won't change for a long period of time. And some of the head and neck guys are going to be picking up many of my patients. You're going to wonder why I didn't operate on all those carotid body tumors and those 1 centimeter papillary carcinoma of the thyroid, because they don't need it. And there are serious consequences of doing it. I'm sorry Rob's not here, because I would have liked to have heard his comment about acoustic tumors. Many acoustic tumors don't need surgery. Remember Dorothea Wolfe? Do you know who Dorothea Wolfe is? She was a pathologist who did a landmark study in the 40s and early 50s on the incidence of acoustic neurolimomas in autopsy specimens. And she found that the incidence of acoustic neurolimomas was 5%. That is, 5% of us here in this room have an acoustic tumor. And in a busy otologic practice, the incidence of acoustic neurolimomas, when I last looked this up, which was about 38 years ago, was 1 in 1,000. So there's a huge disconnect between the incidence of neurolimomas found in a routine autopsy specimen and what becomes the clinical attention. Recurrent mixed tumors of the parotid, most of those don't need to be operated on. And it's not an easy decision to undertake. And I put this in to remind me that never write a paper about a difficult problem that you don't want to take care of. Because in the late 70s, I wrote a paper on recurrent mixed tumors of parotids. And guess what happened? I got flooded with patients. And I mean flooded. Flooded with patients. Active surveillance is appropriate therapy. It's not watch and wait, it's actively surveilling the patients. That's the end of the data. Things I wished I had known.
How do you know that now?
Stanford has always been known as being a little parsimonious. To those of you who are non-English speaking, parsimonious means cheap. And Stanford is always, the university who just raised $1 billion last year is cheap. I'm sorry to tell you, it's a grand institution. I love the place. But it's cheap. It's always been cheap. When the spring meetings, when COSM used to be held at the Breakers, it was held at the Breakers every other year in West Palm Beach, Florida, we had to double up in a room because the hotel rate was just too high. I didn't remember what it was, and so I looked it up. Today or yesterday, it was $525 for a night in the Breakers. So we had to double up in the hotel or stay in one of the cheapies nearby. Well, Dr. Good, Dr. Smith, and I teamed up to share a room at the Breakers. And RLG snored all night. And I mean all night. And Mansfield kept hitting him with the pillow because Mansfield was closer to him than I was. He kept slapping him with the pillow to kind of take him wake up. And, it's just really terrible. So the next morning, I asked him, I said, how'd you sleep? That's my partner. Okay, I wish I had known more that the benefits of fishing are pervasive. And fly fishing is the most challenging form of fishing. And if I had to do it all over again, I would have taught my daughter fly fishing. I regret in retrospect that I didn't do that. She was into horses, and horses are really a 24/7 kind of an affair. But I regret that I didn't sort of make her go fly fishing with me. My son did go fly fishing with me, and we still fish with some regularity. But I wish I had taken my daughter because I don't want to ride horses anymore. I rode them when I was a kid, and I'm too old now. If I fall off, I'm going to get hurt. I don't want to get hurt. So, this is true. You can count on it, because I'm telling you, fishermen are born honest, but they get over it. And Eduardo and Pete Lee, I put this slide in for you. Fish don't get into trouble if they keep their mouth shut. I don't know who the author is of that. I tried to find it, but Google wouldn't tell me. Fly fishing is the most fun you can have standing up. Arnold Gingrich said that. He was editor and publisher of Esquire magazine. Herbert Hoover, our president of the university, for whom Hoover Tower and Hoover House is named, said, fishing is a discipline in the equality of men. He should have said men and women, ladies, because there are some outstanding lady fly fisher people. For all men and women are equal before fish. Steinbeck said it best. Steinbeck was a writer of Mice and Men, Grapes of Wrath. He's from Salinas. He's a Californian. Those of you who haven't read his stuff should read it. It's always been my private conviction that any man who pits his intelligence against a fish and loses has it coming. He obviously didn't like to fish. Of all the liars among mankind, the fisherman is the most trustworthy. That's why you can trust what I'm saying. Now, those of you who are clever will notice that I've actually modified this picture and kind of stretched it laterally to make the fish seem a little bit bigger. But I didn't with this one. This one's from Alaska. It's a nice, this one's a nice rainbow, an interesting rainbow, actually, an escapee from being farmed down in Chile. This is a Alaskan silver salmon. And this is what the morning looks like of fly fishing. And my wife will attest to that because I've taught her how to fly fish, and she's pretty good. She's much better at her stage than I was. Remember, I've been doing this all my life. She's been doing it just a couple of times, and she's really pretty good. And this is what your friends look like. That's myself. My son is in the middle, and Don Goffinet is a radiation therapist, and we're in Alaska in that photo. Here's what fishing in Chile is like. Chile is like the western slope of the Sierras. It's beautiful, it's green, it's luscious, and it's just gorgeous. And that's what it's like. And here's what the fish look like. They're pretty good size fish. And Argentina, Cojuncura River, and fall on the Snake River. I mean, just the sheer beauty of being out in this environment just it's breathtaking. And at night, and particularly in South America, you get roasted lamb and pisco sours. Pisco is a distilled beverage from grapes, and Americans don't do well with pisco. So I would have, if I had known how good it was for my soul, I would have fished more and worked less. And I found out really more about fly fishing when my son got interested in fly fishing, which was about 1982, 83. And that's when I mean, I'd always fished all my life with my father, but I didn't really get into it until the mid-'80s. And I wish I had known how good it was for me. So, and my final words to you are, don't say you don't have enough time, because you have exactly the same number of hours per day that were given to Helen Keller, Pasteur, Michelangelo, Mother Teresa, Leonardo da Vinci, Thomas Jefferson, and Albert Einstein. So you can always learn or do something more than what you're doing now. You can. If you give a man a fish, he'll eat for a day, but if you teach a man to fish, he will buy an ugly hat. And if you talk about fish to a starving man, then you're a consultant. And that's what we are, so it should just come naturally to us. Okay, I want to end with this joke. What did the fish say after swimming into a concrete wall? Damn, that's right. Okay, thank you very much.
Well, thank you. Well, you know, Bill and I did not talk together about what we've learned, but some of the things are quite similar. Now, I didn't do as much fish photography as he has with his special lens that you saw. That distorts what's in your hands but keeps your face kind of about the same. So I don't have one. That's a very fancy lens. And I'm a fisherman too, fly fisherman, but not like Bill. Bill is the real deal. So what I want to talk about is, again, the subject given us. And let's see, we're going to use, how do I move this forward? Which one on the arrow?
Just hit the space bar.
That space bar? Okay, well here is obviously, for God's sake. What do you think? We go on about 4 or 5 different ones. Not just, you know, at the time, IBM was just cash cow. And Hewlett-Packard, holy mackerel, you know. And how about, you know, let's go Menlo Park, Los Altos, you name it. If you know, we could have bought a few things, and we didn't. And the reason we didn't have any money. You know, that was why we knew these were good dogs. We knew that. We weren't that stupid. We knew that. And but we didn't have any money, though it was pretty cheap. But when you have no money, it doesn't matter how cheap is cheap. You know, you still have to have something. But I don't think wanted me to talk about that, because that's, you know, that's good stuff and we all know it's true, but that's not why I'm here. Okay, so, and this is really what Bill alluded to in a different way, is who won't you operate on? And so he put it is there's a number of people that don't need treatment. The problem is recognizing them and then not giving them treatment, because as surgeons, that's what we do. We give treatment. So it's hard to know when to back off, because we've got all these skills, all of this equipment, all of this firepower to do stuff. And then the question not to do it, boy, that's tough. Takes time. And it takes years to understand the question. I didn't understand the question for a long time. And I don't think Bill did either, but because he's got it on there that now he absolutely knows, but I'm not sure he did then, and I didn't know. And then another area here is if we think we go through residency and we're exposed to a certain technique of whatever, and of course that's the best way to do it. That's what we're taught as residents. And do you really know that? How do you know? Think the people at Harvard are learning a different way? Yeah, but it's not as good as our way, right? Not as good as our way. What about the people at Hopkins? What are they learning? Oh, well, not as good as ours. Let's go on and on and on. Let's go down. What about UCLA, SC, San Diego? God forbid UCSF. Huh. We know they don't know what's going on. But it takes a while to figure it out and start changing. If you never change anything after you've been out 20 years, you're still doing the same stuff you did in residency, something's wrong. I can tell you something's wrong, because you should have made some changes. You see, that material I got, that was not so good. This is a better way. And maybe you learned that from who? Maybe you learned it from a colleague, a course, just thinking about it, reading about it, that there's better ways. But you got to look at your own results, and that's what you got to do. Not someone else's results who will report great results with the way they do it, and you maybe can't do that. There's some people who are so good that they can make hard things look easy, and then you try it and it doesn't work so good. Your complication rate is much higher, and you read their complication rate and it's very low, and you say they're big fibbers, you know, and they're not. They're just better. Now, they may not have any judgment. There are people who are technically just terrific, and they can get away with stuff because they can not screw you up. But the problem is you don't need the surgery. That's not good. So, but some of these people are awfully, awfully good, and you don't know that necessarily. We used to go visit other doctors more. Now we watch them on video. Those are edited. Everything's edited, so you can't tell. You know, the screw-ups are all edited out. No one's going to keep a screw-up in. Okay, you're not going to do that. So it's edited out. But the main thing is your results, which means you got to look at your own results, and that's not easy to look at your own results. And that brings me to the next point, is tracking your own results, writing down your cases, how they do, and following up, not just, oh yeah, I did that, that was interesting, I did another septum. And then well, how do they do? Oh, everybody does great, airway looks good. You've seen all those things in the chart, and then they get reoperated on by somebody, and you say, I wonder why they got reoperated, you know. And they get reoperated on because it didn't work out quite so well. You either picked the wrong patient, which is quite possible, or you did the wrong operation. Your super duper radical septoplasty didn't quite do it. And so you need to know that about yourself and pick the one you want. It may not be the one we taught you. You may say, God, the one they taught me is crummy. I want to do the other one, and so you need to know that. At this place, you're going to get a whole lot of different ways. Not every place does that. You have other programs where it's one way, this is the way we do it. And not everybody knows that, but those who've trained elsewhere, they have, this is the way we do it here. You got that? Yes, sir. I got it. Okay, and you learn one way, and you get pretty dang good at it. And we teach you 14 different ways. I mean, the best example is tonsillectomy on the ped service. I love that example. You know, there's, what do we have, 5 different ways that we do, and everybody feels that's the better way. And so you should be able to pick, you know, one of those that you like better, you know. So, but you may find a 6th way that you learn later that you say, that is the real good way. But you need to study your own results, and that's hard to do. Once you leave here, it's hard to do that, and you're not doing it here. The rotation system in residency is not good. But it's the only thing we got. We can't change it. So what happens is you rotate out and you don't know what your results necessarily are, or the results that you did with me, or the results you did with Davude, or the results you did with Bill, or whoever. You don't know. How do you know? You're gone. You know, you're on research. You don't know. So you got to make an effort to find out and ask, because otherwise you're never going to kind of grow and try to put things together as to how you can get better, because that's what we want to do. So if we go on this, Janet was typing this thing up for me, and of course you know that some of these words are YS and some are IES. That's the love of the English language of when does it IES and when does it YS. So all of these turn into IES, and that's not quite correct. But at any rate, you've done 100 of these. You know, these are standard things. Are you any better on the 100th? But more important, how do you know? How do you know? Maybe you're worse. Maybe you're worse. And so you say, well, I'm faster. Okay, well, that's okay. I'm faster. Blood loss is now down to 2 cc's. It was 100 cc's when I started. It's now 2 cc's, okay? My take-back bleeding rate is now 4%. It was 22%. You know, that's stuff you need to know. Hopefully it's not 22%, but sometimes that shows up, that it does go higher, because we go sometimes just what we call bad luck, right? It's never our skill. It's always bad luck. Yeah, so at any rate, but you might be getting worse, and so you need to look at your own data and on even the little thinky things, you know. I mean, just putting in myringotomy in tubes, you know, something that's not very big. What's your results like? How many of them plug? How many help? How many stay open? You know, what's your results, and not the results that the house group, you know, or some other otologist who does a ton of them. So you need to know your own, and we didn't learn that. You don't learn that. And I'm telling you should do it, because if you don't do it, you're going to be at this same level, kind of, well, I think it's doing better, I think it is, and you don't know, and you could. And then this is alive and well, we all get it. Now with people taking more and more fellowships, I'm not quite sure, maybe it's the post-fellowship year where you get it. But as your chief resident, most everybody feels, man, I know it all. You can't help it. It's a disease, and there's no cure for it. There's no cure for it except getting older. That cures you. You should, you know, because you find out that, maybe I don't know it, but it takes a while, because when you come out, man, you've been busy as heck, your practice is huge. You'll never have a practice like you have as a chief resident. You're just working every day, and now you've got limits. They put limits on it. They didn't, back in the old days, no limits. No limits on the faculty either. Is that interesting? So we can get tired and screw up, but you better not, right? Interesting. Why don't they limit ours to an 80-hour week? Damrose is working on that. It's not going to happen. Somebody's got to work. And since we're the only ones here who can bill, which is unfair, I think. I mean, you guys got licenses, but they won't let you bill because you're supported by Medicare. So, but still, this is a problem, because if you get caught up in this thing and you really believe it, and you will, you got to, because you can't shake it. We all get it. You got to shake it as soon as you can, probably 8 years, 9 years, 10 years, and then, you know, say, I didn't know squat back then, you know, and you don't. Okay, and you don't. And there's a ton of data to show this. Now, most of the things we see, you know, a monkey can take care of, you know. Well, you know, that's what's so nice about medicine. There's so many things that are so easy. Med student can come in and do just as well as you can, you know. Well, what should we do for this stuffy nose? What do you think? Well, I think we should give them maybe a steroid spray and then some irrigation. What? There's a challenge, yeah. I mean, wow, yeah. You go 5 years to learn that? Yeah, the GPs all know that. By the time you give, they've always, what ticks me off is they already know, we told the GPs. The GPs do that. And they come to us and nothing's worked. You know, they tried everything, nothing works, and they said, now, and they've had allergy testing, it's negative, and they say, well, you fix them up. We say, what the heck are we going to do? You know, so we say, we're going to do some surgery. Ah, yes, yeah. Well, maybe we shouldn't be doing surgery. Maybe we should say, I'm sorry, this is the best we can. You could be worse. You could have cancer. Okay, but this is going to happen. So if you say, is Dr. Jackler any better today than he was when he got out of the house clinic? Why, yes, he is. Why, yes. How much better? Just a little bit? No, a lot. He's a lot better. Did he know that he was going to be a lot better, that he wasn't hot stuff then? I don't think he did. He's not here, so I can pick on him. But most of us don't know. We think, because this syndrome is very active, and I don't think we can shake it. Everybody gets it. With fellowship, now that you focus on one thing, then you know, so if you're going into sinus, then you realize I'm not as good an ear as maybe someone else, as the ear fellow is. So you may have to comb down on the fellowship. I don't know quite how the fellowship changes, but the chief resident syndrome, it's been around. And so this is easy to say, and I should put, I don't have a quote other than that. I think this is kind of like everybody knows this. If we got to keep trying to get better, and I preach this, you got to keep getting better. And to try and make you as good as you think you are. That's what we want to do, to make you really as good as you like to think you are. And you're not going to do it now. You won't, 10 years from now, you'll figure out that you will be at a different place, and hopefully you're going to be at a much higher place because you are keeping going and moving on and evaluating results. And if you're not doing well at something, you either get better or you drop it. Why you do something that you're crappy at? What's the point of that? Nothing. So you say either I'm going to get better at this, and for some reason I'm not as good as some other people, certainly not as good as the literature, which usually you will not be, but we'll all quote it. We all quote the literature results. It's like, and the people who write, of course, are probably better than all of us, in that one area. They're pretty good, so that's why they write the articles. They're not going to write an article saying how crummy the results are. You're not going to see that. Oh yeah, I really do crummy work. You're going to say, yeah, my rhinoplasty results are perfect. My otoplasty results are perfect. Oh yeah, oh my mastoid work, perfect. No recurrent infections. Oh man, everybody gets perfect hearing. My acoustic results, perfect facial nerve. Of course, they come from good places, good people. And then you quote the same thing when the patient comes in. What's the results of this? Well, and you give the best in the world's results. We've all done that. Yeah. So the best ear guy or lady, and you give that. Well, at some point you'll have your own results, and they won't be as good. So you got to step up and say, shoot, what number should I give? And that's why you don't like to give your own data, because you don't know it. If you say, I don't know my own data, but I think I'm as good as the best in the world, and you're not. But if you don't know, you can think that. And since we know you got the syndrome going for a while, and what you got to do is move on, and you want to try and get better. And here's some kind of little points on that. You got to say, why am I doing it this way? Or why did that complication happen? It's always bad luck, but you never do it because you screw up. But that's what's nice about our brains. Our brains are going to find a way to rationalize bad results. And fortunately, the way the system works is that we'll usually get good results. We usually won't hurt people. That's what's so nice about it. We usually won't hurt people. But then again, we do. Then again, we do. And now the system really punishes a doctor who has a complication. We really punish them. And that's too bad, but that's the way it is. It wasn't always that way, but it seems to be that that's the way it is now. And you're not going to change it, I don't think. I'd like to think that tort reform will occur someday. I don't think so, and there's a large group of people who feel it shouldn't. And many of them are lawyers, but not all. Not all. Not all. And again, we used to have, when you wanted to know how to do an operation, you would the residents would dictate this 5-page note and put every single thing in there. And then we used the 4-0 suture with the P3 needle and was placed, and you went into this detail, you read this 4-page thing because they would take that and use that for the future. That would be their notes on how this procedure went. And it was a pretty good way, except I got tired of reading them. Now we template things now, and we don't do that. But you should make some notes after the procedures. You have to be a little careful. Medical legally, that can be found, that information. So if that patient dies post-op, and you've got your little notes that say, good, really screwed up on this one, then that's not good for me, and it's not going to be good for you either, you see. So that's not good. So you have to be a little bit careful, but you can take notes. I think the most recent one I've seen really did that was Alan Ho. He had this almost like a notebook, and he was always drawing and doing pictures and commenting. I would have loved to read it because I know some of the stuff he said, I don't like this way. That's okay. I'm not trying to convince him necessarily this is the only way, but he did that all the time. And he's gotten in the habit of doing it, and I think it's a good habit. I did it too, in taking the notes. Continuing education sounds obvious. You got to do some to keep your license, you know that, but you don't have to do much. You can sign in out there and still keep your license, and you can sleep through this, or you can do, go to meetings, courses, which I think are more useful. And whether it's an academy meeting or Trilogic, one of those, fine, or whether it's a specialty meeting or subspecialty meeting where you're learning how to do something, I think that's more useful, personally. But this, this one we all know that we should do, but we often will take the path of least resistance. Other things occurs. We get a family. We're doing this. We're doing that. Other things happen. This, I think, is a good thing, whether it's at your hospital, being something more than just, around. So, Medical Society. So from this program, we've had, I think, people who've had every office in our specialty. We've had presidents of medical societies, presidents of hospital staffs, presidents of specialty groups. And then we've had people do nothing, never heard of again, which is okay. What are you going to say? It's not okay. Well, I don't think it's okay. I don't think it's okay, but that I'm not judging you. See, I'm past that. So, but I think it's sad to have gone this far, done this much, and then say I'm done. Well, you're done maybe 50 years later. That's when maybe you're done. But I don't think you're done too early, and I see that, and it bothers me a bit. But I see people who are enjoying what they're doing, and in their town, maybe, and some of them will be here Saturday that we're going to see. In their town, they are it. They maybe are not a huge town. In that town, they are it. When you say, who's the best ENT doc in this town? Bingo. And you say, well, are they writing papers? No. Haven't written a paper ever. No, since they got out. What do they do? They're just a really good doc. And that, to me, is praise and deeds. That's good. I wish they did do a little bit more, like report on some of their data, but they don't keep track of their results. But the results are uniformly good. That's why everybody likes them, and everybody wants to go to them. All the other docs want to go to these people. But they're not going to write papers. We say, oh, well, yeah, it's tough in private practice to write a paper. Now, let me see. Why don't you tell that to Dr. Perkins, or Dr. Powell, or Dr. Riley? I wonder how they did it. Or Dr. Middleman. I wonder how those people did it. Guy, they're in private practice. You're busy. You got to run a private practice, man. Well, and they got 50, 60 papers, and they made profound advances to the field. You say, can that be me? Well, yeah, I think, yeah, I think so. I think so. This, of course, is coming, and this is part of the of what we didn't know. Because could we have invented endoscopic sinus surgery back then? No, we didn't have the right telescopes. We had crummy ones, and we didn't think of it either. And it came out of Germany. See, so if we'd gone to Germany and traveled more, like Kennedy did, we would have probably picked up on some of this stuff. And the first sleep surgery came out of Japan. And if I could have spoken the Japanese language, I might have learned how to do it, because they were doing it in Japan, all of these procedures, including the larynx procedures, just a different Japanese doctor. So it turns out if you went to Europe, that was back in the day, you learned a lot of stuff and you brought it back and became famous in this country. So that's now less true. Now people come over here and learn from us. It's changed. We're not going too much to Austria to learn things, or Japan for that matter, to learn techniques. They're coming here. They're coming here. But this is, there's no reason why can't you find a better way. That doesn't mean you're going to start a company like some people. You're not going to be a Tom Fogarty, I don't think. That's pretty high level to achieve. But you may come up with just a little better way of doing something and write a paper about it or just lecture on it. And again, this is probably true. You don't want to be the first or the last. So here's the last part here, not with a fish. I do have a picture of me it's a standard picture, you're holding the fish. And don't believe this story about Mansfield. I was snoozing away, and Mansfield probably had a bad dream, and that's why he was hitting me. In fact, actually, he probably was hitting me because he liked to hit me. That's probably why. I do remember that. That was a high deal. You're not going to stay at the residents aren't going to stay at the breakers in the future. I can tell you that. That's not going to happen here. You will be staying at Motel 6 down the road, but just remember that Fee Smith and I were at the breakers, and we had to share the shower and do a few other things. But this is really and again, this is I think a question that you should ask yourself. What do I want to accomplish after I leave here? Nothing? Get a practice, make money, have a family, settle down, travel, get a nice car, save money, buy a house. Yeah, nothing wrong with those things. Nothing wrong with those. But that's what you want to do? Is that all of this work? And then what are you going to do after this? You done? Well, maybe. We're not going to, no one's going to push you after here, I'll tell you. You're not going to have any of these staff fussing at you that, why don't you do this, why don't you do that? Well, no one's going to do that. No one's going to do that. So you got to do it yourself. And I think what you want to do is you aim as high as you can. You won't make it as high as some other people, but what the heck, maybe you will. You won't get as, you won't get the big fish like Bill gets, but you'll get smaller fish like I get. But if you get a lot of them, that's okay. And good luck, because luck does help. There's no question that if you're in the right place at the right time, or something comes your way, it's happened to me. I think Bill would say the same thing. That's sure nice, but don't count on it. Thank you very much.